and use it despite, but the Medicare, Medicaid cuts are $416 million
For 2050.
for 2015. Okay, and there's quite a few high deductible plans among those. I know that's my experience in seeing these patients in my office. Okay, and then so Medicaid. Okay, and then the source of that figure that 50 to 72% of people getting health care insurance on the exchange previously being uninsured. What was the?
Yes, that was from the Assistant Secretary for Planning and Evaluation to the Department of Health and Human Services in Washington.
Planning and evaluation. Okay.
And then the other data point on that, again, is I was trying to parse it out in Missouri, at least the best information I've seen, and maybe others have better, is that when all this began, we were about 16% of our population uninsured. We think it's now maybe around
13.5. Yeah, I was understanding that folks on, and I've seen data from a bunch of different states, so it depends on which state, but that the number was flipped, that somewhere between 60 and 85% of either had previously or employer plans that essentially found. So I guess those numbers depend on the state.
And as we get better data in Missouri, we can find that we're not in that range. We should be very much in what you just first.
Okay. All right, thank you.
Mr. Chairman, so just to clarify something, the Missouri has center in number in our city, mainly treated brain state from, and University of Missouri was kind of caught off guard by withholding the funds by different reasons, and so it was never those that. So not, and most all their patients that were already on there. The combination and understanding is it was yes. I heard does the Missouri Hospital Association fund the Missouri Coalition for Health? A group.
I think I'm trying to just sort through who they are. I'm drawing a blank. Please,
All the robocalls that we get in our office.
Oh, sure. Oh, that you're very coalition for health. No, we did not. The activity that we have in our advocacy effort is under the issue of Missouri Health Matters. We don't provide a fund.
Just a quick follow. The proposed expansion would cost $2.2 billion. That was that's all. And you said about 40% of it would go to hospitals, so that would be about $880 million. What percentage of the newly covered would be already covered by insurance? Or I guess another way of asking it, what percentage of those 300,000 that we keep hearing would be people that the hospitals are now taking care of?
That's a good question. My guess is probably a lot of them already taken care of by the hospitals, I'm not sure. As we've shown in data that we've released in the last several years, uninsured numbers hitting emergency departments and compensated care numbers continue to grow. One interesting number that we've seen is that here in the last year, every minute of every day, an uninsured person is walking into an emergency department somewhere in the state of Missouri. So by the time of this hearing for an hour, 60 people somewhere in the state of Missouri were uninsured.
But my question is, what percentage of the newly covered people under Medicaid would be uninsured right now? Do you have an estimate?
What percent of the Medicaid population?
No, the newly covered Medicaid population. The expansion population, what percentage do you expect are now uninsured?
We're thinking all of them.
Okay, so right now, you're getting paid for all, taking care of all, and the hospitals as an industry. The last figure I saw was from 2012, and the net profit of the income over expense of all the hospitals as a group was $600 million. I think it was 640. Do you have any more recent figures?
The latest information that we put out was in December of 2014.
What was the net income over expense of hospitals?
Net income over expense. That I'd have to get back to you on. So I have to-
Okay, but if it was a positive number, that would mean that as an industry, all of the hospitals in Missouri are making money. I mean, they're taking care of all of those uninsured people, and they're not losing. Would that be a fair statement?
Collectively, the margin positive.
Right.
And I think what you want is, in any business, you want a positive margin, and most people want a margin of 4 or 5%, because then you have the capital to reinvest and do the things that you want in any kind of industry. I think what we're seeing in the overall margin is declining, and many of them is below the 2 or 1%, which makes it difficult to reinvest.
So theoretically, I mean, I'm sure that the amount of hospital care would go up for the people, their consumption would go up, the uninsured population, but right now, you're taking care of all of those uninsured people, and you're getting paid to do it as an industry. But now, under the Medicaid expansion, you'd be getting something on the order of 880 million for doing essentially what you're doing now, not counting the increased consumption.
So when we say we're getting paid for it now, it is bad debt. It's charity care.
Yeah, but you're getting paid, but remember the 15%.
So that's the shift over to the other side.
So you're getting paid to shift.
Good shift. I mean, that's how we income. So, the business model of a hospital basically looks like this. So if you were a car dealer and you were repairing cars on a given day, and you had 10 repairs that day, 2 of those repairs you could give it away 100% free. Just have to do it. 4 of those folks coming through your door, you would be giving them a huge discount. And then the final 4, you'd be charging them a premium to offset the others. That's the business model that we have right now. What we'd like to do is for those who are not paying it at all, to get some kind of payment to level things out for all those.
Right, so if you were the auto shop and you're making money, and then suddenly the government is going to pay you for taking care of the poor, now you're making big money.
I think you would see some pretty aggressive negotiation in the marketplace.
How long do you have to pay in the hospital?
The way we see the marketplace moving pretty quickly, I think you start to see changes in the first year or 2. What would be interesting to see is what's going on in some of the other states and how those negotiations, but that might give us an indicator of what we might see here.
But it's been a year and a half, and I asked you if you've seen any changes since for the exchange, and you haven't heard. So I'm just wondering, is it a year, is it 3 years?
I don't think we know, but we are seeing, like I said, serious negotiations in that side, but we still have 13, 14% of uninsured. It's hard to kind of do it partially unless you're kind of calling it.
Thank you. Under the Missouri Coalition for Health, if you can have some people help us find out who's all involved in funding that, I sure appreciate it. Maybe they come by the office. Now, any further questions? Seeing none, Senator Shelby, how would you like to proceed?
Mr. Chairman, being sensitive to Senator Shoup's concerns, on the list I have, both Sydney Watson and Dr. Heidi Miller traveled, so we can do the next. There's 7 of those, and then there's others who have traveled, but those are the 2 I have on the list.
I don't think you're going to much. Take your name.
My name is Dr. Heidi Miller, and I thank you so much for taking the time to hear my comments. This is my second time coming here, and it is so important for me to convey issues of physician shortage that I have actually sacrificed the opportunity to probably see 50 patients in 2 days, because this issue will affect far more patients and affect the numbers of hundreds of thousands. So I'm a primary care physician, and I'm dedicated to serving the same panel of patients for the last dozen years at a community health center. Like all the 28 community health centers in Missouri, we keep our doors open to sick patients with limited ability to pay. We have our eyes open to our patients struggle with work when they're sick. I had the honor of hosting Governor Blunt in 2007 when he took the time to visit our health center, meet with our patients, and understand some of the things that we do. And was invited by him to include his state of the state address in the Since that time, I've been dedicated to helping my patients inside the exam room and outside the exam room. And I thank you for hearing these comments. Today, I'm testifying on behalf of my patients and the Missouri Primary Care Association that represents the 28 community health centers in support of Senator Silky's legislation. Although we have some concerns about the Cure Block Grant approach, we fully support its efforts to have a really balanced conversation about the importance of affordable access to health coverage for Missouri's working poor, many of whom don't have access. Consistent with state statistics, most of my uninsured patients work. My patients drive shuttle buses and they clean houses, they wait tables, they work for catering companies, they stack bricks, they guard our children on crosswalks, and they live, turn, and feed our elders. Our underserved are indeed serving us. Trying to provide outstanding primary care to these patients, however, is not enough. I am not a neurologist. I do not have X-ray vision. I cannot perform a heart catheterization. I cannot replace a limping arthritic knee, and I can't replace a gallbladder. And if we want to rein in welfare firms, I really need help keeping my uninsured patients healthy enough to keep working. I have hundreds of patients who are working, and not only do they not have coverage, but the hard labor in their job actually contributes to their physical ailments. For example, I have a patient who's a professional wedding photographer. He developed this profound inflammatory peripheral neuropathy. I can't figure out what it is. I need an EMG and nerve conduction study, and the doctors on the committee understand that that's about $3,000. That alone will help me make a diagnosis and need a neurologist consultation to figure out how to treat him. As his health has deteriorated, so is his business. Standing still is impossible. So he tips forward while trying to hold his camera. His lancinating pain, that electric pain, is so refractory that I've had to resort to loading him up with oxycodone. And we have figured out that on Saturdays when he's doing a wedding gig, he needs 3 oxycodone just to get through the wedding shoot, but if he takes 4, he literally throws up and has like in the garden while doing the shoot, he's thrown up in the bushes. He came to my office last week with a huge black eye. Got an orbital fracture because his neuropathy made him stumble and fall, and he was too weak to actually brace his fall. And what he said to me was that I was trying to figure out if he had broken his face, but all he cared about, he was so proud to say that he had not broken his hand. So this patient, like many of my others, are really desperate to keep their tools, employment, economic independence, dignity. But he can't do this without his health and health insurance. And I think there's a misconception that Medicaid might perpetuate poverty. But through the thousands of patient encounters that I've had and witnessed, I see that sickness perpetuates poverty. I cannot tell you the number of patients where their health has declined to the point that they can't work anymore. In conclusion, I want to speak specifically to the physician shortage issue. And I'm sure that Dr. Shaw and Dr. Andre can remember this as well. I'm sure this still happens. I recall getting glossy postcards with photographs recruiting me to other jobs. And my other colleagues had it as well as you have. They had pictures of golf courses and happy school children trying to lure primary care doctors to other sites. That recruitment of primary care doctors is on speed. I have received, and this is not personal to me, my colleagues share the same experience. The recruitment for primary care doctors out of Missouri towards states that have expanded Medicaid is so aggressive. I have received personal phone calls at my phone number. Only my parents have that phone number. I have received text messages from recruiting agencies. I have been pulled out of an exam room for something that seemed urgent, and by the time I interrupted the patient encounter and went back to talk to the person on the phone, I realized it was just a recruiting call. The recruiting tactics are more aggressive than they ever have been. In addition, you understand deeply the impact of the physician shortage on patients. Allow me just to very briefly explain the impact on the workforce.
Explain this quickly.
Yeah. About 10 more seconds. 3 groups: medical students, new physicians, and current physicians. When I survey medical students about their reasons for going to primary care or not wanting to, one of the most common reasons is, I'm going to totally burn out, there's too many patients and there aren't enough resources to take care of the patients. It's like becoming a carpenter and not having the hammer to do your job. New recruits. We went 10 months trying to recruit a primary care provider in the past year. During that period of time, we interviewed multiple candidates. Everyone who turned it down before we got an appointment, a position, they left because they went to another state, or they left because it was for a pediatric position, they didn't want to be the only pediatrician in the office. So the fewer physicians you have, fewer physicians you can recruit. No new hire wants to be recruited to an area that doesn't have enough mentorship. And finally, the current workforce, burnout rates are high. Over a third of physicians will tell younger folks not to go into it. About a quarter of physicians wish that they had never gone into it. These are the role models for young, and they are trying to do their work without burning out. With the physician shortage, the year that we had no provider for those 10 months, you add 25% of my workload to my current workload, that's going to cause burnout of your current staff. Thank you so much. Let's take any questions that you have.
Hi, thank you for coming down today. Sorry to get to you last week.
I appreciate that.
Thank you. Now, how do you work at Community Health Center? That's an QHC, correct?
I'm employed by Community Health Center half-time,
Okay,
and then I work with the Regional Health Commission and the Integrated Health Network
okay, okay. Now, where is your health center?
in the city of St. Louis.
Okay, I know St. Louis pretty well. What's your street address?
So we're in the Grove neighborhood, 1352 Manchester.
Grove neighborhood in Manchester. And you're affiliated with WashU School of Medicine. You recently have an academic affiliation with WashU School of Medicine.
I'm not employed by them, but I'm a clinical faculty, so I teach medical students.
Yeah, I am as well. So the Grove neighborhood, Central West End, the Grove neighborhood, South St. Louis, and you're familiar with, of course, the neurology clinic, the rheumatology clinic at WashU School of Medicine. Have you tried to refer your patient with the inflammatory polyneuropathy to that clinic?
So that the patient doesn't have any health insurance.
I understand that.
Okay,
As a jury case.
so that, yes,
And they refuse the
and they
patient.
will only see the patient for cash. And
They won't take it, you as a jury case.
no, and the sad thing is that if the patient walks through the emergency department door,
So then how it applies and they have to take care of it.
then they get a referral. But that, for someone to see me across the system about $100, can't get a patient out of the ER for less than $1,000 to $3,000.
Maybe someone later from WashU School of Medicine or BJC can speak to this. But BJC made a profit. Oh, actually, if you look at their statement, they say excess of revenue over expenses of $450 million last year. And I wonder if we could get an accountant to calculate the value of the tax exemption, not having to pay federal tax, local tax, state tax, property tax. If I wonder if these two institutions are really fulfilling their missions as non-for-profits if they won't see a man in dire straits like your patient who runs the hospital.
Well, here's the deal, I appreciate your process of theory because you understand the difference between an acute issue and a chronic issue. So he's had this chronic deteriorating neuropathy, but there's no emergency issue that will be addressed.
I know, emergency and emergency medical treatment and labor act would apply, but I'm talking about the mission of non-for-profits. The reason hey, if the city of St. Louis could send BJC and WashU a bill for personal property tax and for real estate tax, they could afford one heck of a free clinic.
So I can't speak for that because it's not.
Sure.
But what I can speak to is the fact that we're located in the city of St. Louis. and that we have a lot to offer a new physician who wants to
Sure.
start a family,
wonderful.
or start a new job. And I can't imagine what rural areas are going through in terms of their physician
Right.
recruitment.
Now, just in terms of, you mentioned the physician shortage, shortage means we have too few physicians for the number of patients in our state right now. Yet indeed, about 90% of our rural counties have a physician shortage. But if we expand Medicaid and 300,000 Missourians to the system, how does that make our physician shortage situation better?
So there was a recent study done in a few states that expanded Medicaid and ended up not being as much of an issue. And I can forward that study to you.
Because so I guess the way that would work is the hospitals, the healthcare systems would get more money, that they could attract physicians to their state with higher salaries. I guess that's how it would play out.
It's very hard to attract them now with no coverage for Medicaid, for a subset of potentially Medicaid eligible patients. Yes.
Okay, thank you, appreciate that.
Thank you so much.
Senator Chabot.
Just briefly, I know I have stepped out, but I wanted to know which community health centers you represent.
Human Care Health Centers.
Okay, so I'm more familiar with that.
Any other questions? Thank you for your testimony.
Thank you, Mr. Chairman. We get to call Sydney Watson to talk about the block grant process.
City, will you please come forward? Make it as fast as you can. Not really quick.
Written testimony.
And that's very, very helpful.
I won't read from the written testimony. My name is Sydney Watson, and I'm a professor at St. Louis University in the Center for Health Law Study. For over 35 years, I've researched and written about Medicaid and access to care and health reform at both the state and federal level. I appreciate the hearing today. I appreciate the work that Senator Sylvie has done on SB 419. I wanted to address two issues that I know the committee has had questions about. One is block grants for Medicaid, and also what happened in Rhode Island with what is called their Medicaid block grant. And I want to make 2 points today. First, if you want to move forward with Medicaid transformation or expansion, HHS, the Federal Department of HHS, does not have authority to grant Missouri or any state a Medicaid block grant. And I can talk in some detail about the whys and how of that. But the second thing I want to address today is that the Department of HHS does have authority to grant Missouri a Section 1115 Medicaid demonstration waiver. And as part of those demonstration waivers, excuse me, there can be and are some caps on federal funding. That is what Rhode Island has. That is actually what Vermont has at this point, which is sometimes referred to as a block grant. I want to explain why that Section 1115 funding is different from a block grant and some of the opportunities and risks that would go along with the Section 1115 block grant. As I'm sure all the committee members know, Medicaid is funded as a joint federal program. The federal funds are matched. It's called the Federal Medical Assistance Percentage. The percentage the federal government pays depends upon the per capita income in the state. It ranges from a low of 50% in the richest states to 73% in Mississippi. Right now, Missouri's is set at 72%. States draw down that match when they spend money for medical care, either reimbursement to a hospital, a physician, or managed care. And in that sense, the federal match is open-ended. If there are more people who qualify in 1 year for Medicaid and we spend more money on Medicaid, we can draw down a higher match. On the other hand, the federal match is not completely open-ended because Missouri has to pay the other part, the state share. And I know we are having ongoing conversations about how much Missouri can afford in terms of general revenue funds or the use of provider taxes or other special allotments to pay its share. It's also important to note that the expansion that's in Senator Sylvie's bill has a very generous federal match, 100% for the first year, gradually reducing to 90% in 2020 and thereafter. Block grant is different because a block grant is a set allotment that the state would receive in advance. If costs go up in a year, if there is a recession and more people enroll, it puts the state on the financial hook for all costs overrun. That is a risk to the state if you don't have a federal match. Now we only carry a percentage match. And in fact, that's why many people, myself included, are very nervous about proposals for Medicaid block grants. They look very much like a cost shifting from the federal government to the state government rather than the shared approach we have now. But let me talk about the Section 1115 waiver that Rhode Island passed, that Arkansas, Iowa, Michigan, Indiana, and Pennsylvania all use as part of their Medicaid expansions, and that we also make some use of now at this point. Section 1115.
Could you wrap it up a couple of minutes, please?
Okay, Section 1115 of the Social Security Act allows the Secretary of HHS to waive provisions that are in Section 1902 of the Medicaid Act. That's a lot of provisions, it's not all of them. For a limited period of time, usually 5 years, but some are shorter, to allow states to engage in experimental and demonstration projects to really try new things and different things to do Medicaid their own way. Those experimental projects have to assist in promoting the objectives of the Medicaid Act. And for our discussion today, most importantly, Section 1115 waivers must be budget neutral for the federal government. They may not cost the federal government more over the period of the waiver than it would cost the federal government to run the Medicaid program in the state without the waiver. And that budget neutrality can occur in two ways. Almost all waivers, states ask that the budget neutrality be figured on a per person, per capita basis. So you figure out over the 5 years what your cap per person is going to be and you make it work. That way the state is not at risk if there is a recession and you unexpectedly have more people enrolled, that those costs are borne jointly. States may request, though, under Section 1115 waiver, a global cap that puts the state at risk, both if it costs more for individuals and more people enrolled. Only 2 states have asked for global caps, Rhode Island and Vermont. You've heard a lot about the Rhode Island waiver. That was granted in 2009 at the end of the Bush administration. It was a 5-year waiver. It did have a global cap. You should know that when that waiver was up for renewal in 2013, Rhode Island let their global cap lapse. They decided to continue the waiver, but to use the more traditional per person cap. It's also important to note that Rhode Island got a couple of things that people call a sweetheart deal. If you are interested in global cap, I encourage you to negotiate a deal that's similar to Rhode Island. One, they were able to get a deal from HHS where their global cap was actually higher than what they would have spent without the waiver. No, that's not supposed to happen with Section 1115, but it did. The other deal Rhode Island got was that it could pull out of the demonstration at any time for any reason, so that if it became financially unfeasible, it would pull out. And I will leave it.
Thank you so much. Questions to Ms. Johnson? Senator Rutherford.
One quick question. You said that only 2 states, Rhode Island and Vermont, have asked for a global cap. It would seem a local cap would be bad, and so would they in return for the global cap more flexibility in their projects?
They both got basically the flexibility that other states have gotten under section 1115. They didn't get any more
They
flexibility.
didn't, okay. But when they asked for a global cap in Rhode Island's case, they got more money.
Both of these global caps have looked very generous.
Okay,
And that's a matter of negotiation. The General Accounting Office has been highly critical of HHS in setting section 1115 caps high,
Right.
both with per capita caps and with the global caps. So this is an ongoing federal state tension.
so just per prima facie, you wouldn't think that global cap is something you would want, but these two states negotiated more generous deals than they would have gotten permission, yeah.
Right, and some analysts and researchers looking at it said the explanation is that they are two very, very small states.
Yeah,
And there was relatively little federal money at risk, and they raised the question of how generous HHS would be with
could you ever
those.
do this for Texas, yeah, okay.
I will say, most recently, GAO has criticized HHS for being very generous in the path for the Arkansas waiver, which is how they expanded on Medicaid. So these are kind of ongoing federal intentions we have.
Thank you.
Thank you. I think we'll end the hearing right now. We'll allow Shelby and I will talk. Likely that we'll let some of these other folks speak next week. That will, if that's what you would like. And, but I want to get some of these other bills heard. So we'll come back to Senate Bill 419 next week if that's somebody's desire. And what I would ask that Representative Swan come forward with House Bill 1090 and start her presentation.
Thank you, Mr. Chairman. I appreciate it.
Thank you. I hope we got to most that probably long distance, but not good. And with this, we'll start with this. Representative, you are prepared to take off the go.
And good morning, thank you, Mr. Chair, and members of the committee. Kathy Swan, Cape Girardeau, representing District 147. Thanks for the opportunity to present this bill to you this morning. During a January 2013 inspection of an ambulatory surgical facility in St. Louis, the Missouri Department of Health and Senior Services discovered 14 cases of violations. Violations in infection prevention protocols, busted equipment, copious amounts of dust, and surgical suites, expired equipment, expired drugs, vials of single-use drugs that were meant to be used for one patient only should have been discarded, expired postpartum balloons, lack of appropriate drug handling policies, and hiring personnel without performing a state-mandated search of the latest employees' qualifications. Violations were also found on 2 inspections prior to 2013. Therefore, the bill states, ambulatory surgical centers operating for the purpose of performing or reducing any second and third trimester abortions, or 5 or more first trimester abortions per month, the Department of Health and Senior Services shall make an on-site inspection, investigation, and no direct local or state physical impact. Regardless of medical procedure, all patients are entitled to and should receive the best quality of health care possible. Professionals who follow safety protocols, ensure clean equipment, administer current and unexpired medications, use current and unexpired medical supplies. The bill is about quality health care. Quality health care should not be dictated by geography, by illness, by treatment, by procedure, and certainly not by gender. With that, I would be very happy to take questions.
Thank you, ma'am.
Thank you, Representative, for coming in today and talking about your bill. Actually, on more than Michigan, I agree. And I think in the one place where I agree with you on this bill is that we do need to have more investigations of healthcare facilities in the state. But I think we need to do a better job with the facilities that we are opening here again. And so I know that the Department of Health and Senior Services in the last 15 years I've been in the building has done an awful job when it comes to nursing homes. And I can tell you I have 35 nursing homes in my district, and I get a quarterly, at my request, I get a quarterly report on the status of nursing homes. And it's just a shame that it's very hard to even get one visit per year in a nursing home dealing with their senior citizens who have contributed in those disabilities, who have contributed to our society for so long. So while I understand what you are wanting to do with your bill, I think we need to do a better effort for our senior citizens first. I mean, would you agree? I mean, we've been taking money away from investigations, we've been limiting the number of investigators in the state. And so just because that's where my heart lies, and there's some quality care. Maybe we can work on making sure that our nursing homes throughout the state of Missouri have a better quality care too.
Thank you. Further questions? Senator Shute, sorry.
Good morning. Good morning. I'm sorry, we were working on some testimony from the previous hearing, so I missed your opening. Why are you targeting the abortion clinic in Missouri?
Well, I think for a couple of, I'm not targeting them, I'll explain.
That's the only, there's one facility that this.
That is correct. As a city council member, if you served on city council, I don't think the city council is any different than any others. We, and probably you, have numerous ordinances on the books, but our budget does not allow us to hire someone who will continue to be a watchdog over those ordinances. So the way that our ordinances were enforced in Cape Girardeau is by complaint. So if there was a complaint which violated the ordinance, then it came to our attention, and then we did address the issue with staff members. This is very, very, very similar. This is due to the violations. So it's not targeted as an entity, it is a response to a problem.
So what violations, I'm sorry,
14 pages of violations in January 2013, violating infection control protocol. I have a nursing degree as well. To me, this is appalling. It's
do
irresponsible.
you have those 14 pages of
I do.
violations? I would love to have a copy of what you're talking about, because I haven't heard of those before. Now, so they didn't come to your city council, you're just saying, as you would do in a city council
Correct.
situation.
Yes.
So you received from someone 14 pages of violations by the abortion provider in St. Louis County, or St. Louis City,
It is the report from the Department of Health.
from the Department of Health. And have you examined other reports from the Department of Health about other healthcare?
We have not had issues regarding the other than I'm aware of. That's why we're addressing it.
So was this pointed out to you by the department?
No,
So how did you go about finding this information on this specific provider?
one of the particular lobbyists is a Missouri
Okay, so Missouri Right to Life is saying, okay, there's a problem here, so we want to take a look at it. I'd like to see that before we go forward, and, in that context, I don't know if anybody from the department is here, but I'd like to see if there are other complaints around other healthcare facilities. If we're going to do an investigation or put into place legislation that requires certain things of one kind of provider, I think that we should look at all providers that may have complaints and see if the line is just going to be drawn at somebody who happens to provide a provider that happens to provide abortions, or if there is a larger problem, or if we believe this group, as I think may have been the case, was targeted because they are an abortion provider as opposed to being a healthcare facility that you think may not be up to par.
So, I think this about
All right, thank you.
Thank you. Senator.
Just a question, Representative, you said that report was January 2014, 2013, and that pertains to the reproductive health services,
Yes.
law enforcement, Park and St.
Yes.
Louis. It's my understanding that prior to that inspection, it had been many years since that facility had been inspected. Do you know that number, maybe some of the other witnesses from the?
I do know the number.
Yeah.
There were two visits, there were two in 2013, which was January 31st, and then a follow-up on March 13th.
Okay.
There were none from 2004 to 2008. There were two of them in 2009. There were violations found, the items were corrected. There were none from 2010 to 2012. And then there were two in 2013. And then there has been a follow-up in January of 2014.
Okay, thank you, Representative.
Thank you. Further questions? So what we'll do, we'll call witness for, witness against, the first witness in favor of the House Bill 49. We limit testimony to 3 minutes.
Thank you, Mr. Chairman, members of the committee. For the record, Susan Klein, representing Missouri Right to Life. Crystal on record in support of House Bill 190. And as Representative Swan stated, this is really a women's health bill. This is just ensuring that there is an annual inspection of the abortion facility. And with that, I go on record in support of it.
Thank you. Questions to witness, Senator Schiff.
Have you ever testified for more investigations at nursing homes?
I have not.
Okay. So I have like 35 nursing home facilities in my district, and there's one particularly by my house where I had to call the Department of Health and Senior Services because it was in a devastating situation. There was not even a nurse on the call. So I would love to work with you because of your advocacy for women's health, because there are women who are in these nursing homes that I represent who are not getting quality of care that they need. And since we both support life activities, I would love to have Missouri Right to Life supporting the effort to have quality care in nursing homes throughout the state of Missouri.
Thank you. Other questions? Seeing none, thank you. Please go ahead, Swan. Anyone to testify in opposition of House Bill 190? State your name and lose witness one, please.
Hi, thank you for hearing me out. My name is Megan Mead, and I work for Planned Parenthood Advocates in Missouri. We advocate for the 2 Planned Parenthood health providers in the state. What I want to say today is that Planned Parenthood welcomes inspections, and we learn from them when we're inspected, and you've heard about the inspections. But what we are opposed to is the singling out of one particular provider of abortion for the inspection, when abortion has an incredible safety record. The CDC has found that it's a 99% safety record. So there's no evidence that this inspection mandate is appropriate and would benefit the health of Missouri women over other ambulatory surgical centers where women are being treated, where children are being treated. So it's the singling out of an abortion provider that we object to. And what I wanted to do today was share how this contributes to abortion stigma and the impact that that has on real people's lives. There's a woman I know called Crystal, who in her 20s, she's a working single mom. She's also going to school. She's living at home with her parents and her child. And her number one goal was to finish her education and pick up more hours at work and get a better job because she needed to get out of her house. She was raised there. It was not a loving, it was not a nurturing environment, and she did not want to raise her child in that setting. She knew firsthand what that damage that could do to someone. So that was her focus when she found herself pregnant. She felt herself pregnant and in crisis, so she turned to a crisis pregnancy center, thinking she could get help. She was quite certain she needed an abortion. She wanted to terminate the pregnancy so she could get on with raising her child and getting out of this home that was not loving or nurturing. After several weeks of being led on by this pregnancy resource center, she thought really that they were going to help her get an abortion, but what they were really doing was spending that time trying to dissuade, shame, and scare her out of getting an abortion. She was exposed to videos and material all aimed at making her worried that abortion was unsafe and dangerous and it wasn't a good option. Despite that, she knew she needed to. So when she ended up at reproductive health services, she was terrified. But she was still going to do that because that's what she felt she needed to do for her life and her child. She was so relieved, she told me when she found out it was an amazing professional environment, that the staff were caring, that the facility was modern and safe. And she was so appreciative and was willing to share her story about this at some potential risk, because contacting and talking to you is difficult given her home situation. But what she said was that if she could help one other woman avoid the kind of scary, terrifying situation she experienced, she wanted to do that. I think bills like this that single out abortion providers and try to contribute to that stigma create this tension and terror in women, and that is not a pro-women's health position that I think our state should be taking.
Thank you. Questions of the witness, Senator Schiffman?
So the violations are the infractions or the citations that were noted, the whole plate issues, have those been rectified at the facilities in Wilson?
Yes, they have. As a part of any inspection, once the report is issued to the provider, then the provider must put in a correction plan and works with the department on the schedule for the correction. So the correction plan went into place immediately, the corrections were made. Subsequent inspections will just follow up, and then additional on-site and off-site have not had any additional deficiencies as of that time.
Thank you, sir.
Mr. Chair, are there any national standards that your facility abides by on a yearly or monthly basis?
Yes, thank you for that question. So Planned Parenthood Federation of America runs an extremely rigorous accreditation program in order for any healthcare provider in a community to use the Planned Parenthood name. It's actually been recognized and sought after by other healthcare accreditation processes, trying to replicate that kind of rigor in so many different health centers around the country.
Thank you. Senator Runner.
Again, thank you for your testimony. How late in pregnancy did this first part facility?
Just over 21 weeks.
And so, are you also regulated as an ambulatory surgery center? I believe you are, right?
Yes, that's under state law, we're going to provide this abortion to that amount that is in the bill that you're automatically back to become an ambulatory surgery.
Okay.
Thank you. Thank you for your testimony. Next witness forum. Someone in favor of House Bill 190, you can do it, me too, we're a little short on time.
Morning, Mr. Chairman, members of the Food and Tyler, General Counsel, Missouri Catholic Conference on record support. Just real quick, these, as Senator Meyer mentioned, these centers are licensed now as ambulatory surgical centers, and under current law, ambulatory surgical centers can be inspected at any time at the discretion of the Department of Health. All this bill does is require the center and the state limits that all abortions be inspected this year.
Questions of this witness? Thank you, Liz. Witness forum. Anyone else in opposition to House Bill 190? Seeing none, testimony in favor of House Bill 190. State your name. Please, the witness forum.
Thank you, Mr. Chairman, members of the committee. Samuel Lee with Campaign Life Missouri, want to go on record to support this legislation. And we think it's reasonable for the legislature to determine that there are certain types of facilities or certain types of industries or certain types of care requires inspections and others don't. These are decisions that the legislature has made in the past. I'm not going to read my testimony, but every year in Missouri, every elevator, every school bus, every horticultural nursery, animal shelter and kennel, every public grade warehouse are all places that an annual inspection is required. And I'm sure there are a variety of reasons, health and safety, maybe fraud, maybe historical problems, whatever they might be. We think it's perfectly reasonable that a place where 5,000 or more women a year go to have abortions should have at least one annual inspection.
Any questions of the witness? Seeing none, thank you. Anyone else in opposition? Seeing none, in favor. House Bill 190.
Mr. Chairman, committee, for the record, Karen Messer with the Missouri Baptist Convention and Missouri Family Network, I've been record supporting the bill. Less than said, although I would say that I would be happy to work with any senators on the issue of the nursing home. I don't know how all this connects together, but we do like the idea. We want private parties to be able to put in video surveillance to make sure their loved ones are being taken care of. One inspection from the Department of Health is perfectly reasonable for any institution providing health. I don't care what the institution is. Thank you.
I agree. Any questions? Seeing none, thank you. Anyone else in favor of House Bill 190? Seeing none, Representative, do you have any party comments?
Thank you, Mr. Chair. Patient anecdotal stories unfortunately cannot reveal the information that's